Let's now start with a university question, which is the physiological maternal changes during pregnancy, and these changes are listed here. In ovaries, corpus luteum secretes large amounts of progesterone. It involutes after 3 months till the placenta is fully developed. Since there is no secretion of FSH and LH due to excessive estrogen and progesterone, so no ovulation occurs. Volume of uterus that increases from you can say 0 to say 5 to 7 liters at the end of pregnancy, and the shape that changes from pyriform to globular. Normal weight of 30 to 50 grams that increases to 1000 to 1200 grams due to hyperplasia and hypertrophy of myometrium, along with 3 layers of decidua at the third month, which are, you see, they are listed here. Here the decidua capillaris and the decidua parietalis, they merge after the third month. You already know that menstruation occur in non-pregnant women 14 days after ovulation, and most of endometrium it sloughs away from the uterine wall. If this should happen after an ovum is implanted, the pregnancy would terminate. However, this sloughing is prevented by the excretion of HCG by newly developing embryonic tissue. Essential hormonal factors in pregnancy, they are listed here, for which I will give you a little detail. Human chorionic gonadotropin is secreted by the syncytial trophoblast cells into the fluids of the mother. The secretion of this hormone can first be measured in the blood 8 to 9 days after the ovulation. This is, you see, this information is important for MCQ point of view. So, the secretion that is measured 8 to 9 days after the ovulation, shortly after the blastocyst implants. Uh, the human chorionic gonadotropin, it causes the persistence of corpus luteum and prevents menstruation. Rate of excretion it rises rapidly to reach a maximum at about 10 to 12 weeks of pregnancy, and then it decreases back to a lower value by 16 to 20 weeks, and now it continues at this level for the remainder of the pregnancy. Uh, if we look at the function of the HCG, it causes the corpus luteum to secrete larger quantities of its sex hormones for next few months. By far the most important function of HCG, that is to prevent involution of corpus luteum at the end of monthly cycle. Sex hormones which are secreted due to the HCG, they are progesterones and estrogens, and they prevent menstruation. Plus, they cause the endometrium to continue to grow and store large amount of nutrients rather than being shed in the menstruation. As a result, the decidua-like cells they develop in the endometrium during the normal female sexual cycle, uh, and they become actual decidual cells, which are greatly swollen and nutritious at about the time that the blastocyst implants. Under the influence of HCG, the corpus luteum in the mother's ovary it grows to about twice its initial size by a month or so after pregnancy begins. And its continued secretion of estrogen and progesterone maintains the decidual nature of the uterine endometrium, which is necessary for the early development of the fetus. Now, the functions of HCG they they include not only that the HCG causes the corpus luteum to increase in size and secrete the estrogen and progesterone, but it also has a role in the development and the descent of testes in male fetus. Well, as far as increase in the corpus luteum size and estrogen progesterone secretion, you should know that if the corpus luteum is removed before approximately the seventh week of pregnancy, spontaneous abortion almost always occurs, sometimes even up to the 12th week. After that time, the placenta secretes sufficient quantities of progesterone and estrogen to maintain the pregnancy for the remainder of the gestation period. The corpus luteum it involutes slowly after the 13th to 17th week of gestation. Other function is the development and the descent of testes in male fetus. And mechanism for this is something as HCG it exerts the interstitial cell stimulating effect on the testes, resulting in the production of testosterone in male fetus until the time of birth. This small secretion of the testosterone during gestation, that is what causes the fetus to grow male sex organs instead of female organs. And near the end of pregnancy, the testosterone secreted by the fetal testes that also causes the testes to descend into the scrotum. Placenta secretes both estrogen and progesterone by the syncytial trophoblast cells, and towards the end of pregnancy, daily production of placental estrogen that increases to about 30 times the mother's normal level of production. The difference in ovarian and placental estrogens is that the placental estrogens they are not synthesized de novo from basic substrates in placenta. They are formed almost entirely from the androgenic steroid compounds such as dihydroepiandrosterone and 16 hydroxy dehydroepiandrosterone. These steroids, they are weak androgens and they are formed both in mothers and fetal adrenal glands. Then they are transported by blood to placenta and they are converted by the trophoblast cells into estradiol, estrone, and estriol. Keep in mind that the cortices of fetal adrenal glands they are extremely large. About 80% consists of a so called fetal zone, which secrete dehydroepiandrosterone. Estrogens exert mainly a proliferative function on most reproductive and the associated organs of mother. During pregnancy, the extreme quantities of estrogens they cause enlargement of mother's uterus and enlargement of mother's breasts and growth of the breast ductal structure and also the enlargement of mother's female external genitalia. Additionally, the estrogens they relax pelvic ligaments of mother, which allow easier passage of fetus through the birth canal. The sacroiliac joints, they become relatively limber, and symphysis pubis that also becomes elastic. Then it also has a role in general aspects of fetal development during pregnancy by affecting the rate of cell reproduction in the early embryo. The secretion of progesterone by the placenta that is essential for a successful pregnancy, and it is secreted by corpus luteum in moderate quantities at the beginning of the pregnancy and then placenta in tremendous quantities later. Progesterone causes the decidual cells to develop in the uterine endometrium for the nutrition of early embryo. Progesterone decreases the contractility of the pregnant uterus and then preventing spontaneous abortion. Then it also contributes to the development of conceptus and also acts on breast, which is pre-processed by estrogen. The development of conceptus that occurs even before the implantation by increasing the excretion of mother's fallopian tubes and uterus and providing appropriate nutritive matter for the developing morula and blastocysts. And it also affects the cell cleavage in early developing embryo. So, if I give you the, you can say, summary of the functions of these steroid hormones, means the estrogen and the progesterone. So, we will just summarize these that the estrogens they cause hypertrophy and hyperplasia of the uterine myometrium, thereby increasing the accommodating capacity and the blood flow of the uterus. Progesterone, in conjunction with estrogen, it stimulates the growth of the uterus, causes the decidual changes of the endometrium required for implantation, and it inhibits the myometrial contraction. Mm, Proliferation and hypertrophy of the ducts in breast they are due to estrogen, while those of a lobulo-alveolar system they are due to combined action of estrogen and progesterone. So both the steroids they are required for the adaptation of the maternal organs to the constantly increasing demands of the growing fetus. Now the progesterone it maintains uterine quiescence by stabilizing lysosomal membranes and inhibiting the prostaglandins synthesis. Estrogen and progesterone they are antagonistic in the process of labor though. Estrogen sensitizes the myometrium to oxytocin and the prostaglandins and it ripens the cervix. Progesterone, along with the HCG and the decidual cortisol, it inhibits the T lymphocyte mediated tissue rejection and protects the conceptus. And together they cause inhibition of cyclic fluctuating activity of the gonadotropin gonadal axis, thereby preserving the gonadal function. Now, this human chorionic somatomammotropin, this is also called human placental lactogen. It is a general metabolic hormone which is secreted by placenta at fifth week of pregnancy. Its secretion increases progressively in direct proportion to the placental weight. It is secreted in quantities several times greater than that of all the other pregnancy hormones combined. And its functions include lactation, growth, and increase in the blood sugar level. For lactation, it causes a partial development of breasts, and in some instances, it causes lactation in animals. Due to this effect, it was first named human placental lactogen. However, the attempts to use it to promote lactation in humans, they have not been successful. Interestingly, the placental lactogen, it has it has weak action similar to those of the growth hormone, which causes the formation of protein tissue in the same way that the growth hormone does. Then it has a specific nutritional implication for both mother and fetus. Wonder how? It causes decreased insulin sensitivity. So there is decreased utilization of glucose in the mother, and larger quantities of glucose they are available to the fetus. This nutritional effect it has certain significance. You should know that glucose is the major substrate which is used by the fetus to energize its growth. Uh, and the hormone, it promotes the release of free fatty acids from the fat stores of the mothers, which provide an alternative source of energy for mother's metabolism. If we look at the hormones' role in pregnancy, from pituitary, corticotropin, thyrotropin, and prolactin, they increase while the LH, FSH, they decrease. And from adrenal cortex, the aldosterone and cortisol they increase in excretion, and then the excretion is increased by the thyroid gland and the parathyroid glands also. And in addition to all this, relaxin that is released by the ovaries and placenta. So let's see it in detail. Almost all the non sexual endocrine glands of the mother also react markedly to pregnancy. This reaction results mainly from the increased metabolic load on the mother and from the effects of placental hormones on the pituitary and the other glands. There is also moderate increase in the glucocorticoid secretion, which possibly help mobilize the amino acids from mother's tissue for the fetal tissue synthesis. There is a twofold increase in the aldosterone secretion, which peaks at the gestation end. Now it causes reabsorption of the excess sodium and fluid retention, and unfortunately, it may also cause the pregnancy induced hypertension. Thyroid gland enlarges up to 50%, so there is an equal increase in the thyroxine production. And cause of such increase include the thyrotropic effect of placental HCG, which is a thyroid specific stimulating effect of placental HCT. Placental HCT mean the human chorionic thyrotropin. Increased parathyroid gland secretion that causes calcium absorption from mother's bones and maintains normal calcium levels in mother's extracellular fluid, even while the fetus removes the calcium to ossify its own bones. Its secretion is even more intensified during lactation. And then there is relaxin, which is secreted from corpus luteum of the ovary and the placental tissue, and its secretion is increased by the HCG effect. It functions to soften the cervix at the delivery time. Then it also serves as a vasodilator and increasing the blood flow to the kidneys and the other tissues. It increases the venous return and the cardiac output, and it has also a slight effect on the relaxation of ligaments of symphysis pubis. Let's see now what other ways mother's body respond to pregnancy. The average weight gain during pregnancy is about 24 pounds, with most of this gain occurring during the last two trimesters. And of this, about 7 pounds is fetus, and 4 pounds is amniotic fluid, placenta, and the fetal membranes. The uterus increases about 2 pounds, and the breasts another 2 pounds. Out of rest of the 9 pounds, about 6 pounds of this is extra fluid in the blood and extracellular fluid, and the remaining 3 pounds is generally fat accumulation. As I already told you, there is an increased secretion of many hormones during pregnancy, including thyroxine, adrenocortical hormones, and the sex hormones. The basal metabolic rate of the pregnant woman increases about 15% during the later half of pregnancy. As a result, she frequently has the sensations of becoming overheated. And then there is a positive nitrogen balance. The blood sugar level increases, and there is increased liver breakdown of glycogen, increased insulin. So there is more possibility of developing diabetes or the latent diabetes. Also, pregnancy increases the blood cholesterol level and ketosis. Estrogen, progesterone, and later aldosterone more, they cause the retention of water and sodium, calcium, and phosphorus also. An additional 300 kilocalories per deciliter they are required during the second and third trimester. Caloric expenditure varies throughout the pregnancy. There is a slight increase in early pregnancy and a sharp increase near the end of first trimester continuing throughout the pregnancy. Then if we talk about the protein requirement, an additional requirement of 10 grams of protein per day that is recommended over the non-pregnant intake. Next comes the carbohydrate and the fat requirements. You see, the carbohydrates they should supply 55% to 60% of the calories in the diet, and should be in the form of complex carbohydrates such as whole grain cereal products, starchy vegetables, and legumes. Fat intake should not exceed 30% of the diet. Saturated fats should not exceed 10% of the total calories. Then let's come to the iron requirements. The iron requirements are increased up to 20 to 40 milligram daily. So, supplemental iron is valuable and necessary during pregnancy and postpartum. During the last half of pregnancy, iron is transferred to the fetus and stored in the fetal liver, and this store lasts 3 to 6 months. Let's see now the changes in the maternal circulatory system during pregnancy. Blood flow through the placenta is around 625 milliliters per minute during the last month of pregnancy. And cardiac output during pregnancy that increases to 30 to 40% above normal by the 27th week of pregnancy due to placental blood flow plus general increase in mother's metabolism. But later cardiac output that falls to only a little above the normal during last 8 weeks of pregnancy. The maternal blood volume shortly before term is about 30% above normal. Therefore, at the time of the birth of the baby, the mother has about 1 to 2 liters of extra blood in her circulatory system. The bone marrow becomes increasingly active and produces extra red blood cells. Also, there is an increased fluid retention by kidneys due to increased aldosterone and estrogen. The rate of urine formation slightly increases due to increased fluid intake and increased load of excretory products. Normal pregnant woman ordinarily accumulates about 5 pounds of extra water and salt. First, the renal tubules reabsorption capacity for sodium, chloride, and water is increased up to 50%. And due to salt and water retaining steroid hormones of placenta and the adrenal cortex, this happens. Secondly, the renal blood flow and GFR that increases as a compensation for increased tubular reabsorption. And the cause for that is the renal vasodilation due to increased levels of nitric oxide and the ovarian hormone relaxin. And there is increase in the minute ventilation up to 50% increase, and there is a decrease in the arterial partial pressure of carbon dioxide. Total oxygen used, that is 20% above the normal, and also the carbon dioxide formed. There is increased BMR of the pregnant woman, her because of her greater size and high level of the progesterone. They all increase the sensitivity of the respiratory center to the carbon dioxide. So the respiratory rate that is increased to maintain the extra ventilation because the growing uterus that presses upward against the diaphragm and its total excursion is decreased.